Yep. Hi, good morning, everyone. You are welcome to this health forum. Good afternoon, those joining us from Malawi and elsewhere. All right. So you're welcome to this health forum that will focus on exploring the far-reaching consequences of the recent funding cuts that's by USAID and the UKAid in Malawi on Malawi's healthcare system. So I won't take up much of your time. I'll soon hand over to Professor Heather, who's the chair for the forum today. Before I do that, I just want to remind you that this meeting is being recorded and everything that you share here shall be shared on our social media pages, and pictures taken, they shall be shared on our website as well. So if you're staying in this meeting, it means you've given us consent to share everything that you say. Secondly, if you're joining us online, please remain muted until asked to speak. Then you can unmute yourself, and it will be nice for you also to put yourself on video so we see you and know who you are. Thirdly, for those joining us here in the room, from what I know, there won't be any fire drills. So in case we hear any fire alarms or anything, we'll probably just go to the reception and there'll be somebody to take us out for evacuation. But otherwise, there's nothing. And the other thing is that if you need the ladies or the gents, it's just down the corridor from the reception to your right-hand side. You see the ladies or the gents in there. I think with that, I will hand over to Heather. Thank you.
Good morning, everyone. Landarania, Nancy. Welcome to both colleagues, attendees, both online and in the room, and many friends. Some of you know my health connections with Malawi through the programs of cervical screening and treatment, and some of you may recognise my name as a former chair of the Scotland-Malawi Partnership, a role I passed on last year to Professor Jeremy Bagg, who's here sitting opposite, with the confidence and certainty that he is leading the SMP to further impactful interactions and partnerships. Sadly, the world is not a happy place right now, and the appalling cuts to aid from privileged and wealthy countries do not sit happily with anyone who has humanity in their heart, who wish greater space was being given to equity, equality, compassion, and tolerance. This health forum was planned when we first heard the impact about the cuts, actually, on access to crucial medicines, particularly for TB and HIV. Chad, I wonder if you could bring up that first slide. It's a clip from The Guardian in August, which was actually in our SMP bulletin, but which I think is really relevant as our starting point. So Malawi is facing a critical shortage of tuberculosis drug, with health officials warning that the stocks would run out by the end of September. Well, we're now in October, and it would be helpful if we can have an update as to what is happening. The next sentence is about successes of Malawi, and we really should remember that these are things that, yes, with help from donors, have progressed enormously in recent years. But at the same time, these cuts are devastating for both individuals, country, and the world. As you can see in the last paragraph, the low stock in Malawi is not unique. There's disruption of the global supply of pharmaceutical ingredients, which are worsened by the declining international support and aid. So newly diagnosed patients, if they even get their diagnosis, may be denied access to standard drug regimes. So that's why I wanted to, before I ask any speakers, to actually take another point from an incredibly recent podcast from Princeton University. It's called the Princeton Pulse. And I think we've got a little clip of the introduction from Professor Heather Howard, who introduced this podcast. Thanks.
The Trump administration's deep cuts to foreign aid have sent shockwaves across the world. Nowhere is this more evident than in the realm of public health. With the stroke of a pen, a series of executive orders slashed billions of dollars from global health programs that provide vaccines, medicines, and other vital services to people who live in the world's poorest countries. Of particular note, the administration dissolved the United States Agency for International Development, known as USAID, which has been administering humanitarian aid programs on behalf of the US government since the early 1960s. Projects dedicated to HIV prevention, treatments for deadly diseases, and basic healthcare for children were abruptly eliminated, rolling back decades of progress with severe consequences that could affect generations to come. Without critical US support, vulnerable populations will suffer and millions of lives are at risk. While low-income countries will be hurt the most, all countries will pay the price. Even the United States, as global health systems collapse, infectious diseases soar and spread across borders, and the world is less prepared for emerging health threats.
That last sentence is particularly poignant. Today we're concentrating on Malawi's issues, but I want to just say that we need to be cognizant of the impact that this is having much more widely than just Malawi. This is an open meeting. We want it to be discursive. We have some presentations, but they're actually very short, deliberately short, so that there's time for questions, comments, interactions, and ideas. And I'm first I want to say that we perhaps should divide it into sections so that it's not just, let's just see how it goes, but a little bit of structure. And Chad, the third slide, is that possible? Sorry to...
No problem.
Yeah, the next one was just the clip.
Yeah, of course, it's going to be sticky for me.
It doesn't want to go on. No, okay, well, let me just tell you what the general areas for discussion, there we are. I thought it'd be good for us to focus a little bit on examples of areas which have been adversely affected, particularly TB, as mentioned in that first slide, cervical screening, which will come from Dr. Christine Campbell, and HIV services, which will come from Dr. Kwaladzira. So I'm going to ask Dr. Kwaladzira, are you online?
I was concerned unless he was under another name.
I didn't see his name, but I messaged him to tell him the meeting started.
Okay, well, we can change around if Christine, you were willing to go first. And as I mentioned, this is actually the programme that I've been associated with. But let's hear a little bit from Christine about immediate impacts.
Yes, well, thanks very much. Thanks, Heather, and thanks for the opportunity to present today. Now, I know my colleague, Beatrice Kabota, is online under Rising. And Heather, I don't know, is she scheduled to speak later or will we do a double act? Yeah, good. Well, Heather, thanks for the opportunity to speak. I wanted to flag up that the impact on cervical screening in Malawi was immediate after the cuts. Beatrice shared with us a slide that she obtained from colleagues in the CCAP under Reproductive Health Directorate about the numbers of women screened, particularly based on HIV screening. So as you will know, PEPFAR is a major funder of programs within Malawi to support persons living with HIV, and there are at least 6 organisations which provide screening for women living with HIV. And in the first quarter of 2025, compared to the October to December 2024, the numbers fell from 47,000 to 17,000, and that was just, most of that screening happened in January and February, and come March it had fallen since. Now, Beatrice will update in a moment on how the country has adapted to that, and also how some of the funding has has been either reshifted or has been found in other ways. And Beatrice will also speak on the impact on health personnel who lost their jobs. I wanted to take advantage of the opportunity to flag up two other issues that for us in our community are really important. One is the impact on NIHR funding. As we know, we were privileged in the UK to have important streams of global health research programme funded through NIHR, and that included work in Malawi. Sadly, after the ODA cuts in February, that has meant that NIHR has suspended all that research investment, including in Malawi programmes. And although they say online that they will pick this up and further research funding will focus on global health security, particular diseases of poverty, as of today, there are no updates there. Another impact that I've been affected by in another part of my work is the Flamming Fund. So as we know, antimicrobial resistance is a huge issue globally, a huge issue in sub-Saharan Africa as well. And the UK government invested about 256 million in the Flamming Fund for AMR work, huge programme of work across Africa and Asia that was being highly impactful and affecting both practice and policy in the ground, including in Malawi as well as a number of other sub-Saharan African countries. And that funding has closed, which again impacts people on the ground and has the potential not just for immediate impact but long term. And that's all I want to say. And Beatrice, you were texting me, so I know you're there as well. Thank you.
Thank you, Christine. That set the scene, and also we'll go back to things like the research funding, because that's an issue that is different from the service provision and the immediate impacts, but we'll come back to that one. Over to you, Beatrice, perhaps, to fill everyone in on what has exactly happened this year with cervical screening in Malawi. Thank you.
Thank you so much, Heather. Sorry, we have a very poor network, so I will not put up my screen because of that. Hope you are able to hear me.
Yes, we can.
Yeah, so I can say cervical cancer has been really affected, as some of the things which Christine has already highlighted. As the screening went down because of the stop order. As of now, I can say we are not yet on track, because women, some of the women, we needed to have like community sensitization so that women can know that the services are still going on. But also some of the staffs have gone, some of them have gone back to school. We need to train more. This also is another impact. That means we can't train more providers because of the stop order which was there, but also with the current, though the order was lifted, but in terms of training, that has already been affected because we don't have funds that we can train more providers. So even some of the suppliers has been also affected. So in general, you can say we were at the peak of screening. Now it has really gone down. So this has really affected our aim to reach more women in screening, but with the stop order, it has really affected. So I think I can add that for now.
Thank you, Beatrice. The words "a stop order" are actually ghastly to hear, because the immediacy of these cuts becomes so obviously apparent with those two small words. You said that it had been lifted, at least in relation to cervical screening. So when did that happen? Beatrice, can you answer that? When did that happen? We lost her.
No, she's still there.
Beatrice, can you hear me?
Yeah, it could be just the network. I think she's unmuted.
Yeah. Okay, well, it's been lifted. Is that a good thing? Clearly, it means that funds are needed, though, to return to the, if not the status quo, to begin to build back up. And I suspect this is just one example of what's happening almost everywhere. I wonder if I could turn now to Dr. Kwaladzira to tell us a little bit more both about the HIV, the impact for HIV, which I know is his speciality, but also perhaps, if you can, to mention some of the other major drugs which have been affected more than others.
Thank you.
No, are you there, Dr. Kwaladzira? I thought we saw his name come up. Well, we do have a presentation from him. Are you able to access that
I can,
or not?
yes, I have it queued up. Can't speak to it though.
No, we can't really speak to it terribly well, but there are a few slides in it which I think are quite helpful. So the first slides, I have looked at this. The first slides are about Dr. Kwaladzira's position as the Director of Health Services in Blantyre District Council. And the next slide, where he was going to talk about the objectives and design of a specific program that they have. And actually, Jeremy, I'd be better passing over to you because you know Dr.
I've got a
Kwaladzira.
message coming in from him word by word, I think. Very
Okay,
important
here we are.
word.
Here we are.
Thanks, sir. So Dr. Kwaladzira is the District Health Officer for Blantyre. So he's responsible for over 30 health centres. And he's an individual who is very keen on research and development in that area, as well as clinical service delivery. Can you just take us on to the next slide, Chad? So he's giving you here some idea of the local population. And of course, as we know for Malawi, there are very large numbers of very young people. So the population demographic is the opposite of here. Large number of, women of child-bearing age. And you can also see on the other side the split between rural and urban. So it's a largely urban population that he's responsible for. Okay, thanks, Chad. Okay, so as I think we're probably all aware, Malawi has one of the highest HIV burdens in the world. It is now dropping, so the peak prevalence was in 1999. But he was pointing out these inequalities, higher in women, higher in urban, and actually higher in Blantyre than it is in the capital city, the long way. So the most affected populations, female sex workers, men have sex with men, and clients of those men, and that's from a 2020 study. Next slide. So this was the Blantyre Prevention Project, which was to develop a district-based system that would improve uptake of HIV prevention interventions, and to try to institutionalize it. As we all know, it's easy to do the research projects. It's much more difficult to make them stick long term. I'm not going to speak about the theory of change. So they have now a lot of data. The use of that data, I think, is something I would say that Dr. Kwaladzira has made very good use of, because what he wants to do is show that something can work in Blantyre district and then take it to other regions of Malawi. Next slide. So this is the key for today. So the impact of the US funding reductions on programming in the district. So next one, Chad. So there are still some programs that are working. And of course, as I understand it from when I was in Malawi recently, there were quite significant stocks of antiretroviral drugs. So it's taken a while for the major impact to show, but you'll see that there are other schemes that are not operating at all, that have come to a complete stop. Okay, so strengths and challenges. So one of the positive things was most of the services were actually being delivered by Ministry of Health staff, so that there hasn't been such an impact around losing international development funded staff. It's been about medication, and as I said earlier, there was no immediate stock out because they had drugs in storage, and they have been able to maintain some of those services. There has been an impact on monitoring and HIV testing, and that's again something I think we sometimes forget about. It's the infrastructure. It's not just about having the drugs, also about the viral load measurements, so the laboratory testing, and issues around transportation have also become a problem. Of course, we need to remember that costs of fuel and so on are a big issue in Malawi. This is again all the background infrastructure. And then I don't have any background knowledge in this, but I think the important bit is that little uptick that you're seeing on the graph on the right-hand side, that we are now seeing an increase in the number of new cases since these aid cuts came into play. I can't speak to the individual numbers. So his conclusion was situation still fluid. And they're to reevaluate their HRB programming with the different international partners, with a focus to find other ways of strengthening their approach in the absence of some of the aid that they've been used to having. So I don't know exactly how accurate that was, but I think that covers the main threads. Thank you.
Thanks, very well done, Jeremy. Thank you so much for summarising that. And I think that allows me to open this up. We're talking in this area about services which have been affected, the immediate impacts of that stop, that cut, that drastic action. So I wonder if anyone who's, first of all, online would like to say a few words about any services that they know that have been adversely affected this year and exactly where they are in September, October now. Anyone want to offer a comment from our people online? Not a specific, oh, yes, Chris, okay. Chris Moxon from University of Glasgow.
Hi, so yeah, I'm Chris Moxon from University of Glasgow. I'm normally based in Malawi. I'm a paediatrician. I've based in Malawi for most of the last 6 years. So I mean, I guess I have, in advance this call, I talked to some of my colleagues across the country because it's one of the challenges here is it's very difficult to quantify or to say exactly what's been affected because what the PEPFAR and USAID funding has done is filled a lot of key gaps. So I guess just sort of building on the last talk, what I wanted to say is since I've been working in Malawi over the last 17 years, like I've really seen in HIV, in TB, in malaria, huge progress on reducing the levels of these diseases. And in HIV, this year, there was an announcement that Malawi had met the USAID and the targets of 95, 95, 95. So 95% of people aware of their diagnosis, 95% of those people on ART, and 95% of people virally suppressed. But that is really, really at risk with the cuts. And it's some of the sort of key bridges in the services across the country. So one of the key things is in the in lab diagnostic assistance. So there's a post of people largely funded through PEPFAR funding that are basically people who help with the HIV testing, with the counselling, and they're drastically reduced as a result of this funding cuts. And you've seen a little uptick, but I think it's really, really difficult to quantify the effect that that's going to have. And then they also boosted the amount of clinical PEPFAR funding. It also boosted the amount of clinical officers, nurses, and assistants across lots of clinics and hospitals across the country, which are now, many of which have gone. They, although they were labelled as helping with HIV treatment, they also, of course, were critical for TB diagnosis and treatment, and malaria diagnosis and treatment. And so these are going to have massive, you know, kind of pass-on effects to other diseases which were really being reduced. Yeah, I hope that kind of helps paint some of the scene. And I guess personally, as a paediatrician, it's really upsets me and sort of frightens me, because I've seen, you know, when I first was in Malawi back in 2007, a very high proportion of pediatric inpatients were patients with advanced children living with advanced HIV, of malnourished children on our nutrition ward, with children living with advanced HIV, and every ward round, you know, you'd have a lot of this. Whereas now, at least, you know, recently, a few months ago, that's a rare group of children on our wards, or it's an unusual group of children. It's not, you know, a huge part of our workload as it used to be, and that's at risk. It's this group of, it's these vulnerable groups, as was highlighted in the talk. Men have sex with men, and children who and women of childbearing age. These vulnerable groups, people in like more remote areas, those were whom some of these services provided a vital stopgap, and that's really missing now. Yeah, happy to take questions.
Thank you very much, Chris, from your personal experience, and reiterating, I guess, what Jeremy said too, about the supportive facilities, laboratories, diagnosis, which are perhaps even more vulnerable than the frontline services, where at least staffing capacity has been mainly Malawian. But I wonder if there are any comments perhaps from around the table here to add to this in terms of service and immediate impact, or direct questions for Chris or anyone else who speaks. Christine, back to you.
Thanks very much. Beatrice sent a message apologising. She's really struggling with internet. And she said that the stop order was lifted in July, but with many of the organisations being encouraged to finish the financial year by September. So not quite sure whether that means there's an implication for the next financial year and going forward. So sites did resume screening, but turn up was very low, and part of this might be because women living with HIV did hear that there was no service available, but have not heard it's resumed. So even the communication strategy can take time to build up again. Thanks.
Thank you. One of the other points that I think has come out of this so far, the HIV services actually impact on so many other areas downstream. And PEPFAR has been considered as the most successful of all USAID funded programs ever. So much so that it is one that the US would like to continue. It hasn't abandoned it completely despite that stop. So with a bit of luck, things might improve over time. But this is not just a lost year, but I lost several years. Anyone else like to say anything about services and immediate impact in relation to health? John.
Thanks very much. I guess I've got two comments, questions.
Just introduce yourself.
The first, is it on?
Yes, and introduce yourself.
Oh, sorry, I apologise. I'm John Briggs. I'm Emeritus Professor here at the University of Glasgow. I'm also Chair of St Andrew's Clinics for Children, which funds a clinic, several countries, but funds one in Malawi. Yeah, just 2 points. It's interesting that I took some comfort, not very much, I've got to say, but some comfort that there are stocks of drugs, but clearly these are going to run out. I wonder if there's any indication as to how, bluntly put, how long we have. And that really does concern me and concerns everybody, obviously. It is interesting that one of our other clinics in Uganda have been badly affected, and they've fallen off a cliff edge. And the reason for that, significant of their staff have been, they are Ugandan, that have been funded by USAID, who salaries stopped overnight. And at the moment, they're looking at 20 nurses in the hospitals that we support losing their jobs. They're not losing their jobs in the sense that they're still there, but they're working for nothing and don't know how long that's going to continue. So at least in Malawi, there is less of a cliff edge, but nonetheless, a desperate future. And that leads on to my second question, whether Chris or others that join us from Malawi might be able to comment on. And that is the support for people, particularly in terms of mental health, because I just wonder that as the reality dawns or has dawned on what the future may hold for people, then I can imagine that the mental health of people is going to be, well, badly affected. So I'll just leave it at that. Thanks.
Heather, Gift is now online. I don't know.
Sorry?
Gift is now online. I don't know how to address any of those questions.
Okay. Oh, good to see you online, Gift. Dr Kwaladzira. We know that the internet connection has been very poor. We've lost one or two of our Malawian colleagues who have tried to come on. Jeremy did a brilliant job in going through your slides to tell us a little bit about the Blantyre prevention programme. But there was a very specific question there from the floor here, from Professor John Briggs, asking if we knew how long the drug stocks, particularly in relation to HIV or TB, but any other drug stocks, will actually last. Our understanding originally was that they might have run out by the end of September, but here we are in October. So can you help? Where are we now?
Thank you, Chair. The connectivity is not very good. I hope I can actually be able to communicate. I had sent, I think, a slide deck. I don't know whether I did go through that slide deck or I should just go straight and answer the question. But what I can say is that
Jeremy has gone through your slides, and I think he did it very well. I hope so. Probably not the same way as you would have done it, but that doesn't matter. The gist was there. Please feel free to make any comments that you would like to. And if you have an answer to the specific question of drug stocks now, that would be helpful.
Great. Thank you very much, Chair. So what I can say is that we did have kind of stock outs. I might not be able to speak in terms of the entire stocks for the country. That's why I had actually said that probably we need to get someone from Ministry of Health or probably the program manager, because they are the one that actually coordinates the supply of all these TB drugs countrywide. But so far, we have the situation is actually stable. We have the supplies in as far as TB drugs are concerned. I don't know for how long, because we get them centrally from national level. So the guys up there would be better placed to actually give us a clear picture of how the situation is going to actually unfold. However, when it comes to the actual HIV and AIDS response. From my slide deck, you would actually notice that Blantyre was one of the districts that had the highest prevalence of HIV. And most importantly, note that this prevalence was highest in the key population, about 50%, 40-something percent. And what we had noticed, there is a graph there that I had actually included in my slide deck, that we had made very significant progress in as far as reducing the
The slide's correct, I don't.
Yeah, I know. I might have just got too much bandwidth.
Too much. Yeah.
So,
Here, I'm going to stop.
No,
Yeah.
yeah. Gift, we were trying to bring up your slides again, but I think that's reduced the bandwidth too much. Can you still hear us?
Might have even jumped all the way off the phone.
Gift, can you unmute and we'll try again, but without your slides, which are reducing the bandwidth too much.
Yeah, okay, I'm here.
Thank you. Sigomo. Would you like
So
to
am I
say-
using the slide deck now?
No, we can't show the slide deck because it's reducing the bandwidth too much, and then we lose you.
That's fine. That's fine. Anyway, I can just summarize it, no problem.
Thank you.
Yeah, so basically we had made significant progress in terms of actually reducing the proportion of new infections for HIV in Blantyre. But what we noticed after January, after the Trump order, was that there was a sharp increase now in the proportion of new HIV cases in Blantyre, if you look at the graph on the slide deck. And this was so because US government was directly supporting the management of key populations in Blantyre. And these guys had actually a high prevalence rate of HIV of coming to about 47%. 47%. And after the Trump order, we had actually 4 organizations that were supporting us in that area. 2 of them providing services in terms of drop-in centers, and the other 2 providing demand creation activities. And they all closed shop for a good 3 weeks. But the other 2 that actually were providing the services in terms of drop-in centers managed to actually find other funders from Europe, and they managed to actually restart their services. So basically what this is telling us is that we had actually lost out in terms of tracking our key populations and making sure that we are actually reaching out to them in terms of primary prevention for HIV and AIDS. And the impact was immediate if you look at the graph. However, I have to say that there's been a program running in Blantyre focusing on health system strengthening, especially with HIV and AIDS primary prevention, funded through Bill Gates. And this system actually managed to strengthen the health system by capacitating our health workers in terms of quality management approach to issues. So there was a targeting of HIV and AIDS hotspots within the district. And then once we were actually clear what was happening in the districts, in the various areas, we were able to actually create demand for HIV and AIDS services in a way that the particular populations would actually need the demand by using what we're calling community labs. And we're able to actually get some kind of feedback on how services should be provided. For example, if you're dealing with university students, the way they would want you to actually reach out to them with HIV and AIDS prevention services would be different from if you're actually dealing with like vendors on the street. So we're able to actually come up with capacitation activities that we're able to actually develop these demand creation activities in a tailor-made fashion according to the kind of population that we're actually dealing with. And after we had actually created this demand for HIV service prevention as well as services, as well as products. We're now able to actually provide these products as well as services using quality management principles to the population that was actually in need. And then also we're able to actually integrate this into the mainline health system structures in Blantyre, and it was able to actually support and improve the performance of the services across the board. So when the Trump effect came on board, most of the activities were already being managed by government health workers, but how this approach made a difference was the fact that the health workers now were capacitated and they were able to see how best they could actually navigate the short-term challenges that we were actually facing. So at the end of the day, it was the key populations that were hit the most by the Trump order. And in terms of treatment monitoring, CD4 count, viral load, and what have you, because these also involved high-tech laboratory equipment, and they were also being managed vertically. So these were the two main components that were actually heavily affected. Otherwise, in terms of service provision, HIV testing services, provision of ARVs, and so on and so forth, these were not actually very much affected because we were the ones that were already providing the services in our facilities. But when it came to treatment monitoring, as well as the management of key populations, these were the areas that were heavily affected. I think for now, let me stop there unless there are questions or points I might have to actually clarify. Thank you.
Thank you very much, Gift, for that resume. And it's really interesting and encouraging to hear you talk about the resilience there has been in trying to meet some of the challenges, at least partially, in these immediate months. I'm quite keen to move on to the next section, but would anyone like to say anything else either here in the room on services?
There's a question in the chat.
I think that question
Is that for later?
that question can wait, I think.
Yeah.
If you don't mind. Thanks, Dorothea. But you'll notice chat a comment above from Chris about any resumed funding only promised until March 26th. So it makes for such great uncertainty, which is in itself a major impact, which, as John Briggs said, can gradually impact on the mental health of the people in services and the people who are affected by the lack of the services. Oh, Chris, yeah, okay.
Yeah, sorry, it was just speaking directly to the thing about mental health, which I think is a really important point. And it's just to mention that the resume services are only those that address life-saving or life-threatening issues. And things that have stopped include programs that address mental health issues for persons living with HIV, vulnerable populations. So some of these other peripheral things that were actually vital and critical in these services. So some things have not resumed. And I think it's really important to know that. And another big gap is there was technical assistance that was provided to some of the government agencies, and you may be coming onto that, and so I'm sorry but that's gone as well.
That's really helpful. Thanks for that clarification. We heard that in Uganda, in one clinic, there were 20 nurses who were currently working for nothing. There are others who have clearly lost their jobs and have lost therefore their livelihood. There are still others who will have been impacted, but perhaps have been able to recover in some way. And I wondered if we had in our audience here people who've had personal experience this year. Therefore, this year, 2025, has turned out to be very different from their expectation in January. I know that online we've got Hannah. Hannah Gibson, are you willing to talk about your position, Hannah, just very briefly?
Yeah, absolutely. Hi, everyone. I'm Hannah Gibson, and I'm pleased to talk. From my personal experience, so I was in Malawi until mid-2021, and I left for personal reasons to move back to Scotland. I was the country director for JPIGO in Malawi, where they ran very large HIV prevention and care and treatment programs funded by PEPFAR, a combination of USAID as well as the Centers for Disease Control and the US Department of Defense HIV program, so working with the Malawi Defense Forces. And then I continued to work for JPIGO, working on fundraising and proposal development for Malawi, but for other programs as well. I was actually terminated from my position in May of this year, and so obviously that's my personal story, but it's not as nearly as impactful as it is for all my former colleagues in Malawi that are still, the JPIGO is still operating. I know that Jessica is also in the room, and she has a very personal story that she maybe want to share. But just talking about JPIGO's programs, the HIV funding, some of it has continued. So through the Department of Defense funding, all the prevention work for HIV has ended, but some of the care and treatment work continues. So that was voluntary male circumcision programming that ended. There was also a considerable adolescent girls and young women HIV prevention program that was, also a kind of a flagship program for PEPFAR, known as DREAMS, about keeping young girls and adolescent girls HIV free and in education. And all those prevention programs have ended. And I know that the JPIGO office did, they've gone from 120 staff down to 37 staff. And obviously, since the stop work order and then the actual cessation of funding, so that's kind of the final number. It seems that there is some funding that is coming through for other US government through the State Department, and they are using these large global awards that were already in operation, working in a number of countries, and so that they could be funding in maternal health and newborn health coming through, but it's uncertain what the scope of work is and where that would be in the country and kind of what specific, whether it would be service delivery or whether it would be kind of more in the health systems strengthening piece of that. So that's still kind of under discussion with USAID. So that's kind of my personal experience, but I think questions and points I also wanted to raise as I was kind of looking into this area and just talking with my colleagues who are still in Malawi is the effect that these cuts have had on the employment sector, not just in health, but just overall. I mean, we know the US government was, big funder for the health sector, but also education, agriculture. And in addition to the formally employed or formal employees in local NGOs, international NGOs, the government, as direct recipients of US foreign assistance, there are a number of lay volunteers or staff who receive stipends because they were working and supporting. I can talk from the PEPFAR experience, and while there were moves to transition those into government positions that Dr. Gift mentioned, there are a lot of lay volunteers. I can speak from experience on the Key Populations program, where you had peer educators to ensure that the key populations were sustaining their treatment and also on other, also trying to increase demand of HIV testing. And so many of them were peers. They were not employed fully, but they were given a stipend for the work. And for some of them, that would have been a considerable addition to their income, where they may have been informally employed in other sectors, agriculture, farming, and so on. And sort of also, I think, the service delivery side of it is then also just looking at the impact on the labour sector, I think is something that's really is worth unpacking, and would be interesting to hear more from people who are actually in Malawi on the effect that that's having. Thank you.
Yes, thank you very much, Hannah. You are indeed right, and we will move on in just a minute to the wider implications, such as you're suggesting about general employment. But can anyone else, does anyone else wish to give their experience, personal impact in this year? Jessica.
I actually am not sure what to say, but hi everyone, my name is Jessica Pettit. It's my first time here, so thanks for welcoming me. I am a former Foreign Service Officer with USAID, most recently posted to Malawi. So my information is mostly current as of August, when I moved with my family to Scotland. So a couple comments maybe. There's a lot of comments, but I'll keep it to maybe what we've discussed thus far, and also to say that this is from my personal perspective. I don't represent the US government, and I'm currently unemployed, so separated as of September 2nd. Something we haven't mentioned is family planning commodities. So that was a huge cut in certainly reproductive health services is something that I'd be interested to hear what is happening now. The commodities that were in country with USAID at the time that a lot of this was happening were given to the Ministry of Health. So we felt good about that. And I'm hopeful that they are being used and that nothing has expired or been destroyed. So what else can I say? The devastating period of time. The USAID workforce, just to be clear, like 100% of USAID was under the reduction in force. So any staff that were retained were separated and then hired back under contracts with the Department of State, and that itself was its own process. The health office presence in Malawi was about over 50 staff. Maybe 4 to 5 Americans, the rest of our Malawian colleagues, and all of our Malawian colleagues were separated from service officially as of August 15th. And I believe 4 staff were hired back, health staff, with the Department of State to follow the remaining programs. 1 American staff for all of the USAID mission was also transferred for a different contract in the Department of State. As I'm sure many people experienced, it wasn't a very linear process in how information was being communicated, and not consistent in terms of when you're looking at programs or activities that were cut versus interventions, right? So there were some intervention level assistance that was being retained. However, programs that were doing that work were still being cut. So it was hard to follow to a certain extent because hopefully there will be continuing activities that are supporting specific interventions, but it doesn't mean that the country level project doing those things was retained. I'll stop there, but happy to talk more with folks offline perhaps. Thanks.
Thank you, Jessica. It's hard when you've been so directly impacted, as so many people have. These personal stories are important. Is there anyone else who wishes to say anything about their personal experiences before we move on to the wider aspects of the impact? Coming back, for instance, to a little bit about what Hannah was saying about general employment, and as Jessica's saying about things like family planning. Any comments from the floor, put a hand up if you wish to speak.
There is.
Oh, Barry, yes, Barry, and yes, let's hear from you, Barry. And then we're going to move on to Izabel, so we'll come to you in a minute, Izabel. Barry, go ahead.
Thank you, Heather. Can you hear me?
Yes, yes, thank you.
Thank you. Barry Clarkson, project lead of the Scottish Emergency Medicine Malawi projects and also trustee on the board of Scotland Malawi Partnership. Really grateful to the personal comments made just recently in this meeting from Hannah and others. Hannah touched on maternity drugs. I think that's another area that is quite precarious with supply and demand. We've already supported a few years ago a crisis with maternity drugs in Malawi. I mean, I think that's another potential area of drug challenge. The comments made so far have rightly focused on USAID, which is a massive reduction in humanitarian aid when that program was ceased. But the UK issue is also a problem. When David Cameron was Prime Minister in the UK, he increased international development funding to 0.7% of GDP. That was swiftly reduced by his successors. And recently, the current Prime Minister has removed Westminster international development funding to the Ministry of Defence, and there's really essentially none. And I'm afraid to say, in reality, we're not stepping up; we're stepping away as well. The most recent hailed Scottish international development health programme is really a much lower level of funding than we've seen previously, and only for a year. Those who were at the cross-party group this week in Holyrood would have heard of a project that's taken 7 years to become fully sustainable and handed on to Malawi in the 500 Miles project. And frankly, if the level offered of health project funding by Scotland existed 10 and 15 years ago, we wouldn't have had Heather and Christine's cervical screening project funded. We wouldn't have had the dental fund, the dental project funded. We wouldn't have had the emergency medicine projects funded, nor the Scottish psychiatric projects. So I think we're really in a perilous position at the moment with international development funding. And I absolutely concur with Heather's opening comments about the need for humanitarian support and equity and support for those less vulnerable than ourselves. So I think we really need a call to arms and see what we can do to put pressure on our respective governments and supporters. And I'm not for 1 minute thinking we can influence President Trump, but I think we can do something to influence things here in Scotland to try and help and support and try and mitigate some of these disasters and falling off the precipice that are likely if this continues. Thanks, Heather.
Thank you, Barry. And we will indeed come back, because there's no point in us just being negative in our discussion. We have to think of some ways in which this can be alleviated and what part we as individuals and as a country can contribute. But first of all, let me pass over to Dr. Izabel Nyangu, who's a lecturer in public health at Edinburgh Napier University. And Izabel's going to go through some of the wider implications, which we have touched on all of these talks. But actually, if you can put them over as more generically, and then we can have some more questions. Thanks, Izabel.
Thank you, and hi, everyone. So I thought I could just give a brief on the work that I'm currently doing in Malawi, and mine has been more on helping colleagues in Malawi to develop a more climate resilient health system. And we've been working just to try and see how we could alleviate the effects of climate change on health. And with the funding and the aid cuts, that has actually then compounded the work even further. The gains that have been made, for example, in HIV treatment and tuberculosis treatment, the maternal and child health, all just falls off when you now think of the wider impact that this has actually had on the healthcare system as a whole. And this continues, therefore, to further affect the already existing shortages of vital medicines and supplies in Malawi. And to add on to that, whilst we were trying to, improve the health system, looking at the healthcare workers, the funding cuts have again taken us aback in the work that we've been doing. And, looking at the wider impact, the ability even to retain those that remain within the healthcare system is actually further challenged. And also, the public health gains that we've had in training the healthcare staff just goes all to waste. And therefore, looking at, the wider impact that this has had, because Malawi generally has had, greater dependence on donor funding, and there probably needs to be a look into how the country could be helped to become more independent of donor funding, and for them to shift from the dependence that currently exists on external aid to a more domestic resource mobilization course, which would probably involve and include creating sustainable national financing systems for the country. Because as it is, with what happened with the cuts to aid, that has created an imbalance within the system. It has created a lot of chaos and uncertainty, and imagining how the ordinary people of Malawi are actually feeling. One moment you have something, the next moment it is taken away. That needs to shift, and they need to have a more resilient healthcare system for themselves, one where they know that even where we don't have, the funding coming in, but they should be able to at least sustain themselves. So I think I'm just coming from that angle to say, the imbalance that's going on globally tends to always affect the most vulnerable people. And it is unfair that we continue to allow it to proceed like this. And therefore, thinking around further support for the country so that they can become more resilient for themselves and to be able to have resources that, can be kept within their own reach with or without the turbulence of the international funding. I think that's my contribution for today. Thank you. I'll entertain any questions.
Thank you, Izabel. I think you're absolutely right that it is something needs to change. We all, probably in this room and online, agree that equity and distribution needs to shift. But perhaps we also need to understand that the way that aid was provided was not the best way, and can we find a better one? And so we will move on to that aspect too. But there are a couple of other wider impacts. One is about a specific program of pharmacovigilance, which has been also stopped. And I'm going to ask Dr. Francis Chiumia to speak just about that. And then we'll have a little a word or two about the research impacts. And then I want all the ideas that you've got. So first of all, Dr. Chiumia.
Thank you very much. Good afternoon, everyone. So I'm Francis Chiumia, and I'm based at the Campbell University of Health Sciences. So just to give a background about the pharmacovigilance program is that at the Campbell University, we have been supporting the Ministry of Health through a memorandum of understanding with the Pharmacy and Medicines Regulatory Authority to contribute to the monitoring of the safety of medicines. And so through our programs, which we are focusing on the collection of safety data, trying to identify safety signals, and also being able to collaborate at international level with the WHO UMC, where we do share these safety reports. We had to make some significant progress in terms of safety surveillance of medicines and vaccines in Malawi. And so we have been managing the Regional Pharmacovigilance Center within the university, where we also had some dedicated staff. We are looking at a number of safety issues, including one of the major challenges that we have been struggling with in the country of substandard and falsified medicines. So indeed, the aid cut has affected us significantly, because most of our activities, they were being supported by the USCDC. So with the aid cut, so starting from end of September, the CDC completely stopped supporting the pharmacovigilance program. And so what we have seen is that this impact is mainly affecting us in terms of disruption of the medicine surveillance, and also vaccine safety surveillance program that we have been conducting, whereby we are able to collect safety reports from health facilities and be able to assess them and send them for some other further assessment, including the causality assessment. But also within the Pharmacovigilance Center, we had some dedicated staff, including the database officer who was managing the data, and also the pharmacovigilance coordinator who was doing the ground coordination of all the pharmacovigilance work. It means these ones have eventually lost their jobs. So even some of the activities that we are having, because one of the other major challenge that we have is that there is a lot of knowledge gaps in the facilities among the healthcare workers on how they can incorporate pharmacovigilance in their daily practice. So we have been conducting some training programs for the pre-service and also the in-services, and what these ones would not actually be able to proceed. And also, we are making progress in terms of setting up pharmacovigilance regulations, which we are focusing on how people would be able to report adverse drug reactions, the reporting channels for the substandard and falsified medicines. And so it means that there might be some regulatory setbacks, because these were some of the works that were still in progress, including the establishment of hospital pharmacovigilance systems. They were not actually very mature. Things were just starting being put in place, and we are anticipating that a lot of these activities would be heavily.
Thank you, Francis. That was really helpful. I find the idea of a lack of pharmacovigilance and safety monitoring actually potentially lethal. Drugs are very expensive, used wrongly or in wrong doses, or modified to make them stretch further. All those things that could happen if you have no pharmacovigilance in place, whether it's centrally provided through the university or at the local level. And as you say, the knowledge gaps at the ground level must be considerable in this area, and without support from units like yours, I think that is a potentially devastating consequence, which could be very long lasting. And in a way, it ties up with one of the other things, which is not directly on service delivery, the healthcare, immediate healthcare, but the research partnerships themselves, which are being affected by cuts. Because what does research do? Well, I've got two things that I just want to say. First of all, good research undermines the ability, the lack of it undermines the ability to discover tomorrow's breakthrough interventions. So we're not just losing this year and 1 or 2 more years, we're losing decades if we don't keep up with that. It also, and this in a way is something much deeper for individuals and populations, it dismantles the knowledge infrastructure that helps establish more efficient ways of addressing global poverty and disease. Coming right back to what Izabel was saying, how do we get equity if we're actually not even investing in ways to find better systems for poorer communities? So I wonder if one or two of our more academically associated people would like to speak about the impact on research, just for a few minutes before we open it wider for what can we do. Anyone? Chris, do you have any comments about the research funding as opposed to the service delivery?
I mean, cuts in NIHR and UKRI funds have meant that there's 2 studies that I'm aware of that were funded, but that have not been able to go ahead. One of them on central nervous system infections, one of them on hepatitis, and another study that requested a no-cost extension that wasn't able to get on. So, I mean, there's multiple direct effects. There's effects on multiple projects at KUHeS because of USAID and US funding cuts. A whole load of our malaria research in the community and at the hospital has been affected by uncertainty and paused US funding cuts. It's really profound. And again, you know, you really are well articulated. Uncertainty is such a big problem for these things, and it really affects morale and as well as, you know, people's jobs and the ability to do the work.
Yeah, thank you. Uncertainty and short-termism, I guess. Tracy, have you got anything you'd like to add, perhaps?
Yeah, sure. So allied health person, really, as a WASH lady. But I think we see exactly the same things as Chris touched upon, as Christine touched upon. I have an NIHR grant at the moment, and we're back and forth about no-cost extensions. The working experience in respect of aid cuts has been incredibly challenging, as we know, over the last couple of years in Malawi, with fuel cuts and community-based work. So, but, you know, for the NIHR, to give them their credit, they have no idea what funding they have in the future, and it's very difficult for them to say that. So then we're actually doing research and we're not being able to see the real impact from it in the long term. I think places like Malawi are where research makes a huge impact. We see the evidence go straight into action in most circumstances, which we often don't see here in the UK. And by cutting things like research, it not only impacts the ability to find better pathways, as you said, Heather, better systems and ways that we can improve it, but it also, I think, starts to narrow what people are doing. We start going back into our disciplinary silos as well. So we start working in these little spaces. Well, really, for the last decade, we've been working harder and harder to be interdisciplinary, to look at the connectivity in the whole system. There's now a danger as money and research and ODA reduces that we become more protective again, it becomes individualized, and we're going backwards, not just in terms of what research is delivering, but how research is conducted in this space. So yeah, I have a lot of worries about it, and fabulous, as we all do, fabulous young researchers in Malawi who have amazing careers ahead of them if given the opportunity that we want to support. So we hope the light will be seen. Thank you. That was my point, the capacity building in the country. I've got colleagues in KUHeS who've actually of 20 young researchers involved in TB and malaria programs in the south of the country. And these are all young people, different stages of that early career trajectory, who had plans that would have contributed so much. And so they're scrambling for funding for that. Thanks.
Yeah, also speaking to that dimension of research, like for me, I work in One Health, and when USAID was cutting their funding, one of the heavily affected programs was the ECTAD program by the UN FAO. And at that point, as the University of Glasgow, we were in conversations with the UN FAO to actually complement the ECTAD program on zoonotic diseases in Malawi. And we're going to bring in the implementation research component of the work we were going to be, we applied for a grant from the university to bring in the research component of the interventions on zoonosis, rabies, and other diseases. FAO lost their funding. As the University of Glasgow, we got our funding, but now we can't work with FAO anymore on the research work that we're supposed to do. And the idea with that research work was to actually look at the operationalization of One Health on how we can, better implement interventions on zoonosis. And so as a country, we're even stuck now on how we're going to operate on that side of front. So indeed, as everybody has said, I think the 8 cuts have affected multiple dimensions of research work, but as well as the implementation of different interventions. Yeah.
Sorry, maybe just to add one thing, going beyond research, but to data, and that the Demographic and Health Survey program was canceled. So I think Malawi was fortunate in that we had just completed implementation of the DHS. I think the initial results were launched. I don't know the status now in terms of finalization of and dissemination of results, but globally, I think DHS potentially ending, hopefully something coming up from ashes, I don't know, is also kind of a huge loss.
Yes, these are all really, they're devastating to hear. We know that many of us, particularly if you're white-haired like me, we've been lucky enough to have years of both expansion and certainty. Yes, of course you don't always get your research grants. That's an absolute given. But the ability to develop those cross-cutting partnerships, and now where one partner loses and another doesn't, actually multiplies the impact even more. So I would like to turn, for this last 15 minutes that we've got, it's gone quite quickly. Actually, Chad, could you bring up the last 2 of my slides, please? The first one is actually showing some comments, which I wonder if we can take as something we need to run with. We've concentrated on the negative. The next one, possibly the one after, or is it not going to move?
Just as a
No, it's just stuck.
Laggy sometimes when we get in.
Well, okay, well, actually, I think that what the next slide that I wanted to mention was what ordinary people really think about donor aid anyway. So one of them came up from Olivia Giles' talk at the Scottish Parliament on Tuesday, when in answer to a survey about providing a new health service, the answer was, it's better to do without something than to get used to having it and then not be able to have it. This is what always happens with donors. That is such a terrible indictment of what we've been trying to do. If we have failed to transfer, if there has been failure to implement services that are achievable in Malawi and other countries. We had the same early on in our cervical screening program. I would rather train and trust my eyes than rely on a machine which will not always be there. And that was by one of our most competent Malawian VIA providers. So raising expectations, and there is no doubt that some aid has done that. Not just in what they can achieve by doing, but actually in salary levels for staff, making it much worse when they are no longer funded. And also, something Olivia mentioned, the resentment at perpetually having to show gratitude. Why? If we have an equal world, if we have a compassionate world, that's a given, not something that should be seen as a gift or aid from one person to another, one country to another. So if those are things we can get past, can we look at the next slide? There might be some optimism about the future if we accept what we have done already and try and look for ways of actually promoting the best bits. So although we're being anxious about research, we know that there are already quite strong evidence base in several areas which could be applied immediately. Perhaps we just need to take some leaps. And we absolutely do need to ask countries much more thoroughly. Most countries know what they need, what they would like, but actually are realistic about what is affordable. So how can we get them to there? So I think that the capacity amongst people in training is actually one of the biggest things that can perhaps help. So how best can we continue to support training, education and training, to allow countries to introduce what they want rather than actually relying on budgets? And I know there are some positive signs in various countries, such as Ethiopia has got a new health tax, and Uganda has just doubled its health budget. Okay, it means something else has got to go. We're all struggling at the moment for where money should go. But perhaps Malawi too needs to rethink its health priorities. It's got wonderful strategies, some of them too difficult to implement. Perhaps that's a starting point. And therefore, what can we do to help promote that? So open to you for these last 2 days. Some ideas, please. Ideas we can take forward. We are, after all, the Scotland-Malawi partnership. We can preserve that. We can preserve all our links as best we can. How can we help Malawi offset at least some of the devastation that this year's cuts have caused? Over to all of you, not me. Glasgow, great, thank you.
Yeah, I thought I'd speak here as quickly as possible, because I wanted to say this in the previous beat where we were talking about the examples of areas of effect and personal experiences. So I guess I'll speak wearing multiple hats here as a board member of the SMP, as a member as well, but I think primarily I'll start with the fact that I'm Malawian. I think hearing these conversations and even how the stories have unfolded, I must say I'm filled with anger, and I hope that's a feeling that I can naturally contribute positively to this conversation. In Malawi, we have a proverb which says, "Zitseba non zadonse," right? Meaning whatever comes here affects everyone. I don't work for USAID, right? So I don't have a direct personal story to share about that. But what I am as a Malawian is that I live with relatives who are living with HIV, who are living with TB. And they know I work in the health sector. I'm a social scientist, right? I'm not really a doctor. But the fact that they know that I work in the health sector and they hear, oh, there's no more funding for HIV and AIDS, they're coming to me to ask me, is there hope for us? What's going on? Are we dying? Are we going back to the old days where we used to have a lot of death? because you can't access medicine. And I have no answer for them, honestly. I don't know, right? It's what I have to deal with every day. Aunties, uncles, cousins asking me these questions. I go to the communities in Malawi for my research work on rabies. Nothing to do with this idea, whatever 8 things that are happening. But the community members will ask me, because I mentioned the word health in my conversation. What's going on? We're hearing all these stories and narratives. And how is the government going to help everybody else? Now, with that feeling, I think for me, it's a question going back to the government of Malawi as well. And I think the role that we can play to answer your question is that when you wrote in your last slide around setting the priorities, I think it's important that as an SMP community, we force, or I don't know, we nurture or we work with the government to make sure we're setting our priorities right. What I hate to see, even after the USAID or whatever aid cuts we're talking about, I'm still seeing the Ministry of Health, buying the brand new Toyota Cruise. You understand? For the directors. What is that? Who's financing that? Is that really the urgent thing we need to do right now? Should we be looking at something else? All right. It's their decision to make. Yeah, sure, where they put the money. But when you ask them, they also tell you, oh, well, the donors are willing to finance this. Really, is that the position we should be holding as people supporting and financing? Or should we be financing things or system changes or practices that will help sustain the systems? All right. So I think it's that conversation we need to be having, a practical conversation around what's the most urgent thing we should be financing right now and supporting, and not the petty needs of some hungry politicians or civil servants that want to enrich themselves. It makes me hungry.
I like angry Bosco.
Yes, carry on.
I think just to add to that, I think absolutely we need to be angry. We need to, and it's about that capacity building. And my key thing was a word I remember you were surprised by it a couple of years ago, Heather. Projectization. It is the killer of any of this stuff being sustainable. We go in with funding for a certain period of time, whether it's 1 year, 2 years, 5 years, but it's still seen by politicians, by civil servants, by local communities as a project. And it's going to start and it's going to end, and then maybe something will change, or maybe we'll just go back to the same. She wasn't lost thing, but we go back. So I think that's also that mentality change that we need to nurture, that this is about changing that fundamental system, looking at new ways of doing things, making them effective, to help those that are being left behind. The most we seem to keep forgetting that part is the most important part of the SDGs. Those that are being left behind the furthest are the first target, not the middle, but those that are furthest behind. And I think that's what we can help that narrative, but through people like Bosco, so that it's coming from Malawi for Malawians and not from the Azungu sitting in Glasgow.
Thank you, Tracy. What about online? Anyone like to make a comment here? Because, you know, for once I'm going to say that one of the things that I actually do support the Scottish Government approach in saying we will react to Malawi's requests. And actually, that's really tying in with what you're saying. We haven't been listening well enough. We need to listen more, and therefore, but also Malawi and other countries need to reprioritize, as you say. Now we've got a hand up from Izabel. Izabel, what would you like to say?
Thank you. I think just to add to the comments that have already been made, I would also want to encourage the, Malawi to also consider what other countries within the region are actually doing to tackle the challenges that have come from the aid cuts, because USAID was actually in many countries, not only in Malawi, and all other countries have been equally affected. Now, some of the projects that have been occurring, for example, with Jipaigo, have been not only in Malawi, but in other countries like Lesotho as well. And it would be an advantage, you know, for the country to also look at other similar projects that have been working for HIV, for TB, and also, you know, vulnerable groups, maternal and child health, and try and find common ways of moving forward within the region. And not for them to, you know, not for Malawi to feel like they're in isolation, or the problem is only affecting themselves, because it has really been an impact within the whole region and many other countries worldwide. That could also help in hopefully pushing the Malawian government towards increasing the finance for, you know, the local finance and budget for their healthcare system, and also trying to mirror, you know, the financing towards the health budget as other countries within the region. There should be other drivers to Malawi. And even as we think as the Scotland-Malawi partnership of moving forward, we also need to consider how other partnerships in other countries have managed to move forward. What has been going on with drug supply and management? How have they been going around issues around healthcare services? And we also try to push that towards the Malawian government and the Ministry of Health, hoping that that is going to end up changing their approach to health within Malawi, and hopefully it will help them to also move to the, you know, same levels as the other countries within the region. I think that was just my contribution. Thank you.
Thank you very much, Izabel. And sadly, we're running out of time. We will have to say goodbye to our colleagues who are online, to thank you all for participating. We didn't have so many questions in the chat. There was one about the UK level of funding, and I think that was responded to really by saying just how much it has cut, but no one could give an exact figure. And comments will be